Let's get started here tonight. Once again, I'm Richard Mulvey, and I'm very happy to be here to share this program with you tonight about managing your medications for heart failure. And to figure out how to advance the slides here. Okay, I got it. So I'm a clinical pharmacist here at Essentia Health Heart and Vascular Center in Duluth. I'm actually a board certified cardiology pharmacist. In addition to that, I'm also a board certified pharmacotherapy specialist with added qualifications in cardiology and a certified cardiovascular care coordinator, which means I've run out of a room for initials on my name tag, but that's okay. But it means I know a few things about medications, and hopefully I can give you some tips and tricks tonight that are going to help you feel better about the way you take your meds and just feel better in general. And so a little bit more of a background. Oh no, it doesn't have the animations aren't going to come in the way I prescribed them. So you've seen the secret here at the very bottom. I also have a fishing problem, but I also happen to run the heart attack program here at Essentia too. And I also personally am interested in research, and I have 18 clinical publications to my credit so far. So I'd like to start out with a fun little cartoon here. I've already diagnosed myself on the internet. I'm only here for a second opinion. And I'm guessing that might be about how some of you guys feel tonight. Things that I'll tell you tonight might prompt you to go to the internet to look things up. But I'm going to do my best to be more of an authority for you on what might be the best thing to do for your medications. So managing your medications for heart failure, it can seem, confusing and overwhelming, but it really doesn't have to be that way. So let's start out with a quiz, and this is just on your honor, but we'll just think about this. Do you feel confident that you understand your heart failure medications? A, not at all. B, somewhat confident. C, I'm pretty confident. Or D, are you super confident? And I want you to think about that as we get towards the end of this program. And if you're already super confident, well, then I'll invite you down to help me give this next presentation. But hopefully we can move you up from the A zone closer to the D zone here. Again, I want to give you some tips and tricks on how to help you maximize the benefit of your medications. Make sure you're getting the most out of them, but at the same time, minimizing the side effects of pills. Because if you take too much, definitely side effects can happen. I do want to pause and recognize this is sponsored tonight by the Heltney Endowment. And I worked with Dr. Carl Heltney for many years. I've been here for 28 years at Essentia. And even though he was a cardiologist and I was a pharmacist, he taught me a lot. And I can recall an encounter up in the hospital when I needed him to co-sign for, I was ordering a Coumadin dose for his patients, and I couldn't get a hold of him, and the patient needed the medication, and we got it through, and I ended up, disturbing one of his partners to get them to co-sign. And then the next day I said, I'm sorry, Dr. Heltney, I didn't get a hold of you before I did this. And he stopped me. He goes, stop right there. Did you do the right thing for the patient? I said, well, yes. And he goes, well, then you have nothing to worry about. You've done the right thing. And I think that spirit of Dr. Heltney teaching me that, and hopefully teaching a lot of his colleagues and patients, is we want to do the right thing for you, the patient. And Dr. Heltney started practicing here in Duluth in 1979. He eventually moved up to be the chief medical officer for Essentia. But he launched our innovative congestive heart failure program here at Essentia. And literally right in this room, he recorded a program 5 years ago talking about this. And he said, what bothered me a lot was these patients were being readmitted to the hospital. And he's like, there has to be a better approach for caring for these patients, but also the family that is involved. And that's what's inspired us to really work hard as a healthcare team across Essentia to make sure that we're doing our best to take care of not only the patient, but recognize the family and the caregivers that are involved. And this kind of collage here just helps to remind us that it does take a village to take care of our patients, especially when we're dealing with heart failure. So let's start out now with what actually is heart failure. Many of you hopefully on a call like this know a little bit about what heart failure is, but as the heart starts to not do so well, it can get bigger, and it can lose efficiency over time, and we can get fluid that can build up in the lungs and actually down in the ankles. And it's a condition where the heart muscle is actually weakened. It just can't pump the volume of blood that it normally would. And it can be called congestive heart failure when it becomes a symptom where the blood is backing up like into the lungs or into the abdomen, or even, down into, the ankles as well. And so this cartoon on top just shows, a normal left ventricle of your heart. That's the part that pumps to the rest of your body. And as the heart doesn't pump so well, it tries to compensate by getting bigger. And it works for a while, and then all of a sudden it doesn't work so well as a good strategy. And then hiding behind my head here, you can see, more of a diastolic, a thickening of the heart too, which makes it a little bit stiffer, and it doesn't pump so well either. But either way, we're dealing with a situation where the blood flow isn't optimal, and we have lots of things we can do about that, and we'll talk about that tonight. But this is kind of what causes some of these symptoms. So I think of it like a bicycle tire and a pump. When you try to pump up that bicycle tire, it's really easy at first, right? But then as the pressure builds, it gets harder to push. And then if you have a cheap bicycle pump like me and you let go, it pushes back on you. Okay. That's what kind of happens in the heart when we have heart failure, and we're also dealing with higher blood pressure and things like that. And so we're trying to lower that pressure that the heart has to push against. And then also, we don't want to be putting too much pressure on the blood that's coming into the heart. So there's a little bit of an analogy there to help you understand how that one works. Let's think about what causes heart failure. Well, heart disease, atherosclerosis, cholesterol, and clogged arteries or blockages or narrowings. Folks that have had a heart attack, and it may have actually damaged part of the muscle, and it just doesn't grow back in heart tissue very well, if at all. Also, high blood pressure, valve problems, infections that can happen in the heart. And we're actually learning some stuff about COVID now that's very interesting, as well as some congenital defects and alcohol and drug use. And here's a picture of a heart that's being fed by an artery that got blocked, and then it was a heart attack. And this black area kind of is a cartoon to show us, maybe an area of the heart muscle that literally was damaged or even died. The rest of the heart is doing okay here, but it has to compensate now for that. So a lot of times for a lot of our patients, that might be the type of heart failure that they have. And so what are the symptoms of heart failure? The patients often, not all of them at once, certainly, but they may be short of breath. They have this swelling in the feet and legs that I talked about. But they also get fatigued and they're weak. The heart isn't pumping as well, so you're not getting blood flow to your heart and your lungs and your brain and organs. You may have a little bit less appetite. We have irregular heartbeats, more urination at night, sometimes chest pain. Also weight gain, which in some cases is more of a fluid gain, water gain, because of too much salt and other things. But the shortness of breath and the abdominal swelling are kind of the classics. And here's a cartoon, again, showing, and the abdomen swelling, sometimes we call it ascites. In the lungs, we can call this pulmonary edema or fluid, or even down in the ankles too. Sometimes we'll get some of that. And again, it's because the heart may not be pumping as well as it used to. And this decreased blood supply to the organs leads to kind of a cascade of effects there. So in the heart, in the US, heart failure is almost borderline epidemic. We have to be careful how we say that word nowadays with COVID, but over 6 million Americans right now have heart failure, and it might even actually be higher than that, with enormous costs to the healthcare system. There's well over 1 million admissions to the hospital each year, and we want to do everything we can to avoid those admissions. It implies that there's problems, but it creates enormous inconvenience for the patients and their family, and we want to keep you at home if we can. And heart failure, no matter how you look at it, it's very serious. Up to 50% can die within 5 years of diagnosis. Now, that doesn't mean you're going to die in 5 years, but without treatment and without proper care, that's certainly a possibility. But I bring good news. There's a lot that you can do for yourself, and we can do to help you to tip the odds in your favor. So that's the next question begging to be asked. What can you do to help yourself? And for so many of my patients, it comes down to this. We call it therapeutic lifestyle choices, but life's about choices. and you can choose to take your pills or not take them. We tell you about limiting your fluid so you don't have too much fluid on board for your heart to pump. Obviously, every one of you on this meeting tonight has probably gotten a lecture on salt. Watch out for salt and processed foods and things beyond the salt shaker. And then we want you to exercise. We want you to keep her moving. And I can't tell you how many of my patients that I see, the ones that are go-getters, the ones that want to keep moving, they're the ones that end up staying in better shape, and they tend to feel better about themselves. We need to recommend limiting alcohol intake, and for goodness gracious, don't smoke tobacco if you can. A little bit of a fun guy on the internet does the Manitowoc Minute. He's kind of a comedian, but one of his signature phrases is "keep her moving." And I think about that all the time when I talk to my patients, is the value of doing that. But bringing it to a more of a serious quote here, Surgeon General C. Everett Koop, one of my favorite Surgeon Generals, has this famous quote, drugs don't work in patients who don't take them. And it's so simple, but it's so true. And hopefully that's why we're here tonight, to understand that important fact. So statistically, 1/3 of all heart failure patients do not take the medications that we prescribe for them. So if you're in a room with 3 people, look to your left, look to your right, or is it you, or is it all of you some of the time? But we know that it's really tough when you have heart failure, because you're on a lot of medications, to take all of the pills right all of the time. For lots of patients with heart failure, they're on a minimum of 7 prescriptions per day. And for a lot of my patients, it might be up to 13 prescriptions a day. And it's tough. But we know adherence or compliance to taking those pills, it's all over the map, the data. But we know that it's almost impossible to be 100% perfect, but we know that the odds could be much better for a lot of our patients. Some statistics say maybe 20% to 50% of our patients don't take their pills the way we ask them to. And we do have other data showing very clearly that when patients don't take their pills, has much worse outcomes in heart failure, including more hospitalizations, including death as well. So what do I mean by non-adherence? It's kind of like non-compliance. But what we're talking about is if you omit or you forget to take a dose, or you just don't take a dose. You might purposely skip a dose. You don't get your prescription filled, or you run out, or the pharmacy ran out, and you're up against it, and it's gone. You take the wrong dose. You take 2 pills, or you forgot, and you took an extra one, or you forgot, and took the other pill twice. Taking it incorrectly, hopefully that's kind of self-explanatory, but most of your pills for heart failure are oral. Some people do have patches and injection type things, but basically, as well as inhalers, and it's easy to kind of screw things up. It's also possible to take someone else's medication, especially if in your house. Husbands and wives oftentimes are swapping medications, and I don't recommend that. I'll just leave it at that, but it does lead to trouble. As well as just simply, I don't want to take that pill anymore, and people just stop taking it. So unfortunately, my animations are going to be screwed up here tonight. So I ruined the joke here, but this acknowledges that it's impossible to be 100% compliant. And we know that you're going to want to have some fun once in a while, but we want to make sure that you don't have too much fun. So I hope that that's the message of that slide. Just a little bit more data. Up to 30% of our admissions are due to people who don't take their medications correctly. And patients who had a heart attack, if they didn't take their medications better than 75% of the time of what we asked them to do, they were 260% more likely to die within a year than those who took their pills. So to me, that's a very sobering statistic. Here's kind of a peaceful quote, if you will. Life isn't measured in hours and minutes. It's the quality, not the length. And that's great. I love, thinking about philosophy and other things, but I also like Linus Pauling in a way, because I want to have it both ways. I want to have a great life, feel better, but I want to live longer too. So the question is can we have it both ways? And hopefully by taking your meds and taking care of yourself, you can not only feel better, but you can live longer. So that's kind of how I look at that. So how do we improve, your adherence, your compliance, your ability to take your pills successfully? And this just came out in some guidelines from the American College of Cardiology literally 2 months ago. And it's like the number one thing. We got to take a time out here, consider the patient's perspective. It doesn't do any good for Richard here to tell you, take your pills or else. We need to think about what's important to you and what works in your life. And as a pharmacist, when I do medication management with my patients, we really try and think about it. Do you get up early? Do you get up late? Do you eat breakfast, or do you work nights, or do you, what are the ways that we can customize things to match your perspective? And then again, acknowledging the goals of therapy, feeling better and living longer. I don't know what more you want. For me, I want to catch more fish, but that's part of feeling better, I guess. But to understand the impact of some of the things that we choose can impact how we should design our drug therapy for you. So again, from the recent guidelines, and this is just two months old, but it's timeless. I've been doing this 28 years here. This is kind of makes sense. We want to simplify your medication regimen whenever possible. I have patients who are setting alarm clocks. I got to take pills 6-7 times a day, and this one with food and this one without. So they get up at 4 a.m. and then midnight. I'm like, just stop. You should never need to take your pills more than 4 times a day, hopefully less. And we break it up into breakfast, lunch, supper, bedtime. And if you need to take it more than that, you need to come and see a pharmacist like me, because we need to make your life more simple. Because if you have to take pills more than 4 times a day, it's just a recipe for not being successful, not to mention being miserable. And we don't want that. Again, this is right in the guidelines, and it says plan pharmacist visits for complex medication regimens. So yay, pharmacists, finally, we made the guidelines. And they also give credence to one of my favorite tools is a pill box, and we'll talk about that, to be filled for up to a week at a time. So when we think about adherence, success rates, you're never going to be 100% compliant. I get that, but we want to shoot for a good average. I'd like to shoot for upper 90s. I want to give you guys all an A, but there was an interesting trial here that showed that when patients took their meds less than 88% of the time, their survival was 221% worse. So their conclusion was you need to shoot better than 88%. Well, I'd like to shoot higher than that, but this should be a wake-up call for those of you who are missing 10% or 15, 20% or more of your meds. This could be a wake-up call for you, that this could be a problem, because statistically you're putting yourself at risk for more hospitalizations and more problems down the road. So here's kind of a classic drawer full of pills, and then our 7-day pill box, which I love this design. It's breakfast, lunch, supper, bedtime, or morning, noon, evening, bedtime, whatever you want to call it, same concept. And then to have a 7-day supply, that really does seem to help a lot. So do you have a pill box? And if you don't, I strongly encourage you to think about getting one like this, and it might help you out. And remember, don't mix pills, especially husbands and wives or partners and houses, and at your home. Don't share pills. I know it might be tempting. They're both on lisinopril, and I ran out and he ran out or she ran out. But do your best to avoid that. Oh, and then also, sorry about this. Don't mix pills in a container. I have patients that come in with their pill bottle and they're like, well, that's my warfarin, that's my amiodarone, that's my potassium, and then I think that's my Lipitor, or it's something else. I don't know. I'm like, So yeah, don't put all your pills in one bottle, please. And also want to emphasize how important it is to have a medication schedule. And to carry it with you. I have so many patients. Do you have a medication schedule? Oh yeah. Well, where is it? Well, it's at home. Well, you need to have it with you in your wallet or your purse. Or it's easy for them to say, well, it's all over there on the computer at the clinic. They know what I'm on. Well, I got to let you in on a little secret here. They don't always know exactly everything you're on, because you have more than one doctor. Your foot doctor says, quit taking that pill. And your kidney doctor says, well, take 2 of these now. And your endocrinologist says, do this. And do you think these doctors all talk to each other? They try, but you are your best advocate. You need to carry a medication schedule. And I want you to know both the brand name and generic name. I had a patient who got his pills filled at different pharmacies, one at the VA, one at Walgreens, and one here. And one bottle said lisinopril, one said Prinavil, and one said Zestril. And all he knows is he had pills left, he paid for it, and it said take 1 tablet daily. So he did, boom, boom, boom. Well, guess what? They're all the same thing. And he tipped over. He had a syncopal or hypotensive episode, and he ended up in the hospital. So it's very important that you know that each drug, unfortunately, is complicated, but they have a brand name and a generic name, and try and get those written down. You've heard of the term OTC, or over-the-counter drugs, like Tylenol and ibuprofen that you can buy without a prescription. But a lot of patients, they don't think of those as drugs, and yes, they are. You need to put those on your med list, as well as herbal supplements. If you're taking Siberian ginseng and St. John's wort, yes, we need to know about it, and you need to have it on there. Storage. Another interesting thing is where people keep their pills. Pills are like food, they're perishable. You need to think about that. You want to keep them dry, keep them out of the light. You don't want to let them get wet. And ironically, one of the worst places to store your medicine is in the medicine cabinet, because in the shower we have lots of the humidity, and humidity actually breaks down pills and makes them sticky. Also, you want to keep the pills away from the kids or grandkids, and so what do? You set them up on top of the refrigerator. Well, there's all that heat coming up off of the top of the fridge, and that actually breaks down pills. Or they put them on the windowsill on top of the sink, because that's where the water is. Then the sun's shining on them. And then if you spill them in the sink, then they all get wet, and then you're picking them up with your finger, and you got little orange stains on your finger, and you're putting them back in the bottle wet. Rule number 1, don't put wet pills back into a bottle of dry pills. Dry them out on a paper towel. But I know this is not very clinical, but hopefully, this is the real world. This is what happens that kind of messes up pills and can lose their potency. One pill that really loses its potency fast is like nitroglycerin pills. They're better, but their potency literally can start to fall apart within less than 6 months or so. So you got to do your best to keep those things in their original containers and kind of keep them dry. All right, so let's talk about what happens when you take a medication. This is a little bit more technical, and if it's too technical, I apologize. But this is kind of a plot down from left to right is time in hours, like 1, 2, 3, 4, 5, 6. What happens to this pill? And there's a concentration in our blood. So this green line, as it goes up, we're absorbing that pill. And then right about here, it stops absorbing. And now our kidney and our liver, for the most part, start getting rid of it through your urine or metabolizing your liver. And then it drops. And then between these blue lines is what we call kind of our therapeutic window or our therapeutic range. So we want to kind of keep the curve bouncing along in there to do the good things before the bad things happen, shall we say. And let's just keep this concept in mind when I think about blood pressure medications, because almost all of you are taking at least 2 or 3 pills that can do something that impacts your blood pressure. And what I like to do is to avoid taking them at the same time, because we get this curve that comes up and down. But if you're taking 3 pills that do that, it kind of amplifies that curve. And kind of in our COVID area, everybody's, in the rhetoric of let's flatten the curve, right? Well, we've been trying to flatten the curve with blood pressure pills for 30 years here. If you don't take them at the same time, they kick in at different times. So then you get more of an even keel, and you're going to feel better. Your blood pressure is going to be better controlled, and you're going to have better control in the morning when the next dose is due. So on top of the timing of not taking them all at the same time, got another little secret here for you. Most of your pills, especially your cardiac pills, can be taken with food, and they probably should be. A, it helps you feel better in your stomach, but B, it slows down that absorption. When you have food in the stomach, it doesn't release that contents into your intestines to be absorbed in your bloodstream as fast. So it's more of a sustained release. So you don't get that high peak level like on the graph I showed you. It just kind of comes up slower, and then later, 24 hours later, there's still more left in your bloodstream. So you feel better. So it's like two strategies to kind of flatten the curve, if you will. Don't take all the blood pressure pills at the same time, and then take them with food, unless for some reason the doctor tells you not to. But trust me, most of the heart failure medications you can take with food. There is one exception. Many of you might be taking a water pill. A water pill means that it makes urine. It helps reduce the fluid in your blood by letting your kidneys, causing you to urinate it out more. And Lasix or furosemide is kind of our classic workhorse. However, it's not as consistent based on whether or not you have food in your stomach or not. If there's food in there, it can actually mess up how well the Lasix or furosemide works. So in the heart failure program here, at least, we've converted most of our patients over to this other one. It's called Demodex or torsemide. And that one is not impacted by food hardly at all. So that may be an issue that you and your doctor or your nurse practitioner, PA, are working with, but just be aware of that. But other than that, almost all of like the lisinoprils and the other beta blockers, they can all be taken with food. Another thing that can mess up that absorption is interactions with other things like fiber and antacids. There's milky, chocolatey type antacids like Milanta or Pepto-Bismol. Don't take your heart pills within an hour or so of those things, and Metamucil too. By the way, Metamucil is great, keeps you regular. It lowers your risk for colon cancer. It lowers your cholesterol, but it also lowers the absorption of pills if they're in the stomach at the same time. But if you space it out by an hour or two, then you're good. So don't stop your Metamucil, just don't take it at the same time as your other pills. So let's bring it back to heart failure, kind of the history of our drugs that we've used and our strategies, and up till what we're going to be doing now in the next couple of years. So back in the 70s, we didn't know a lot about heart failure back then. We gave digoxin and we gave water pills, the diuretics. In the 80s, we would give things known as inotropes and vasodilators that helped to make the blood vessels bigger and tried to make the heart pump faster. In layman's terms, it might have made the heart burn out faster. We're not sure. But it wasn't the answer to heart failure. And then along comes the ACE inhibitors and beta blockers. You've probably heard your doctor say this, or ARBs, angiotensin receptor blockers. And they're great. They're the first drugs that have showed us, that we can let heart failure patients live longer and feel better. And then along comes the mineralocorticoids. Spironolactone is another medication that has also helped with this remodeling that happens when we get you on ACE inhibitor, beta blocker, and spironolactone. The heart kind of reconditions itself in a way to a new normal, if we will, to keep the heart failure from kind of deteriorating. It helps us keep the strength, the power that we have left, and that's good news. Then in the 2010s, we started thinking more about earlier diagnosis, getting aggressive before the symptoms start kicking in. We had cardiac resynchronization therapy and devices that do amazing things. And then in 2017, we had this ARNI, angiotensin receptor neprilysin inhibitor. It's a funny term for a drug that's known as Entresto. You might have seen it advertised on TV. And that's been shown to actually be very helpful too. And it's in the new guidelines as well. And also another drug that came out then has to do with reducing the heart rate. We haven't used that as much yet, but who knows, in the future, we may see more of that. Now, please don't try to read this. I apologize. I know it's really small, but this is from our guidelines that literally came out 2 months ago. But I just wanted to give you a kind of a snippet of, this is the playbook of what your doctor or your nurse practitioner or PA is going to be looking at, or the nurses, to know that we have starting doses of these drugs and target doses. And that's where the tough part comes in, because I can't just start you out at a high dose of a beta blocker like metoprolol tartrate or succinate at, say, 200 milligrams a day. We need to start low and go slow. Our new guidelines tell us that we can try to start titrating these things every 2 weeks if possible. And with beta blockers, it's really cool. You might feel cruddy for a day or two or three maybe, but then all of a sudden there's the new normal. And then we lift up the dose a little bit, and then you feel cruddy for a while, and then there's the new normal. But if we know that if we can get your doses up to a higher dose, you are going to live longer. And that's what was proven in clinical trials. So that's why we work so hard to kind of titrate you from a starting dose of these kind of tools in our toolbox to a target dose. And again, try not to read exactly what it says here, but just know that these drugs that you're taking are based on tons of research and clinical trials that show us what works and, more importantly, what doesn't work. So I was going to ask you, did you want to review ACE inhibitors and beta blockers? And my guess was, how about no? So I thought we could be done with that by now. But what I wanted to highlight here, and what I already showed on one of my earlier slides, is again, the recent guidelines. A shout out to pharmacists. So if you are a caregiver or even a provider that happens to be watching tonight, don't underestimate the value of what a pharmacist can give you to kind of look at what meds they need to be on, but then start restructuring the timing and investigating deeper into herbals and supplements and other drug interactions, as well as a reminder how important it is to fill those pill boxes and use those as reminders. All right, are we ready for the future? I don't know if I have a drum roll for that, but what is the future of heart failure medication? So this was the past that I talked to you about. So now what we have, there's some diabetes medications that have been kind of a 2-for-1 type drug here. They're known as SGLT2 inhibitors. And those are now out and actually acknowledged in these guidelines to be used. So some of our patients, we will be adding this new drug category for some of them. This is being researched right now. There's it's called a guanylate cyclase stimulator. Don't worry about the name of it, but just know that there's progress being made with research there. There's also new potassium binders out there. And sometimes as heart failure progresses, kidney function doesn't do as well. And we get a little bit in trouble with our potassium levels getting too high. And some of the medications we give you cause your potassium to get too high. And so there's now some patients may benefit from these potassium binders. Other patients, as kidney disease in line with heart failure can progress, some patients actually get anemia, low blood counts, and low iron, and we do all these things to try and boost it. Erythropoietin. There's research being done on a new class, HIF-PH inhibitors. I won't put too much more into it, just to let you know, but that's going to help for patients to kind of trick them into thinking they're at altitude, like they're climbing Mount Everest, and then the Sherpa advantage, and then the body creates its own natural red blood cells. It's pretty cool. And then there's another class being looked at, cardiac myosin activators, that is kind of like what we thought about way back when, the inotropes, but it seems it might be a little bit different. So we're going to cross our fingers and see where the research goes on that. Again, some of these may not make it to market, but just to let you know that we're not done yet. There's a lot things that we can do to improve heart failure over hopefully the next few years here. So let's talk about what you should not be taking when you have heart failure. And a lot of people kind of look past this one, but you got to pay attention to what dose of aspirin are you supposed to be on, if you're supposed to be on aspirin. For a lot of our patients, it should be simply the baby aspirin, the 81 milligrams. Just because you go to the store and the 325 milligram bottle is cheaper, don't buy it. More is not better. More is more bleeding is really what we found with aspirin. And for our patients that take excessive amounts of aspirin, you also get other impacts of that are not good for heart failure. So try to keep the aspirin down to the baby dose. You've all heard, hopefully, what an NSAID is, a non-steroidal anti-inflammatory, commonly known as ibuprofen or naproxen or Aleve. Great for some pain and inflammation, but not so great for heart failure. It causes our kidneys to hold on to a lot of salt and a lot of fluid, and it can make heart failure actually a lot worse in some other ways. So we really try to back off on those. So kind of heads up for that. You probably already know that, but I need to mention it. And then herbals and supplements. I talked about this before, but make sure your provider knows that you're on them, and then get them checked out. Make sure it's safe. Make sure it's something that you can take. Well, I got aches and pains. Well, what can I take for that? Well, Tylenol is your friend. Acetaminophen is the generic name. That is not going to interfere with almost any of your heart failure medications. And then some patients, if they have severe pain needs, they may be on opiates like Loratab or Percocet, But as you know, we have to be aware of the problems with opiates and, addiction. But in occasional use, generally they don't have a lot of interactions with your heart failure medication. So that's a bonus there. So speaking of herbals, yeah, here's me talking to Bonnie, my patient, if you will. Some of you may have met Bonnie. She's a fantastic dietitian. But it's just so classic that patients are taking an herbal or supplement that can increase their risk of bleeding. And so many of the herbals and supplements do that. And that's why we got to get that checked out. And so maybe a little bit of a joke here about, natural versus modern. It's all natural. It's drug-free. Well, I'm sorry, chemicals are drugs. And just because something says it's natural doesn't mean it's safe. So again, we want you to get that checked out. Statistically, we know that over 50% of Americans use some sort of a dietary supplement, if it's simply a vitamin or, like I said, like the St. John's wort and ginseng and all these things, and CBD oil and all those, which can also interact too. So how do I know if these supplements that I'm taking are safe? Well, first of all, you got to consider the source. Read the label. This guy should have read the sign, right? But this is what you're looking for. It's this little green and yellow circle, and it says USP, United States Pharmacopoeia. And they check for manufacturing, for good manufacturing standards, for potency, purity, and make sure it meets their criteria. And if you want to look for that, this is a little bit old. There's probably more now, but Nature Made's a common drug. They have USP, or just ask your pharmacist if they can get you USP products if you need them. So quiz time. Do you guys recognize this guy? I'll ask you guys, no, the studio audience. That's Vincent Van Gogh, who cut off his ear to impress his girlfriend or something. So how about this painting? Do you recognize this one? And so that's a famous painting known as Starry Night. And Van Gogh was famous for painting in these big orange and green smears. Well, guess what the side effect of digoxin toxicity is? It's seeing things visually disturbed in green and orange smears. He was diagnosed by his 19th century French physician for dropsy. Well, dropsy, it's in the Bible, the core fluid drops to your ankles and gets puffy. Does that sound like heart failure? It is. And they found by taking digoxin, they could help that a little bit. But there's other herbals like Siberian ginseng is a classic that will actually help make this toxic. So if you start seeing Van Gogh paintings on the wall and you have a patient that's on digoxin, it's time to get in and get a blood level drawn or to reevaluate that. Also, yeah, the timing of the pictures flying in here, but I really worry about some of the sources of fish oil. This is a picture of me in Duluth. For those of you who need a clue as to where I caught this fish, it's right by the wastewater treatment plant. but that's a little bit of a joke, but we do have to worry about some of the foreign products coming in, raising fish in commercial ponds with pollutants that are toxic. And so we got to watch out for that. I get a lot of questions about grapefruit juice sometimes. It can interact with lots of drugs. I'm not going to focus in on them now, but I'll take a little quiz. Oh yeah, there's the answer. So much for animations, but you can't fake it out. So how long between grapefruit juice and how long it's safe to, take your pills? Well, you can't fake it out. It lasts for 3 days. You have a grapefruit, that impact lasts 3 days. Now in moderation, you can probably have a little bit of grapefruit, but you can't say, take your grapefruit in the morning and take your pills at night and fake it out. It doesn't quite work that way. So, all right, so what's next? I'll tell you a little story. We call them case studies, but they're also stories. I'm going to start out with an old hero of mine. I was a trumpet player when I was younger, and Dizzy Gillespie was one of my favorites. But I always think about him when I think about some of my patients who are on a medication regimen like this. And this gets back to what we were talking about earlier, taking all of your pills at the same time. And so he's on a classic cocktail of medications that a heart failure patient might be taking, and he took them at the same time. And then he felt really cruddy, later in the morning and throughout the day because they're all kicking in. And then we wake up in the morning and they've worn off, and then the blood pressure is sky high and he's just not feeling good. So this is a classic example of where we want to spread them out. And one of my rules of thumbs is kind of like the alphabetical sort of. ACEs and ARBs are already in the AM. That'd be like your lisinopril or your Entresto or your losartan. A diuretic during the day, like the furosemide or the torsemide, you don't want to take that just before you go to bed, because then you'll have to wake up in a few hours and have to go to the bathroom. Digoxin at dinner, because then we can measure a good blood level in the clinic during the day for that. And then the beta blockers, a lot of times at bedtime, again, spreading that out makes people feel better. So now a little bit more of an in-depth case study of a patient I'll call Walter. He has heart failure, high blood pressure, cholesterol. He had a heart attack. He has atrial fibrillation, funny heart rhythm. And he has a history of TIAs, transient ischemic attacks. But he's actually doing pretty good. He's on a classic list of medications that many of you are probably taking: the aspirin, the lisinopril, the metoprolol, furosemide. And then he's on a couple other funny things here too that don't make sense. Otherwise on famotidine or, wow, ibuprofen. Remember heart failure and ibuprofen? Hydroxychloroquine, where'd that come from? Well, we've had a lot of interesting things happen this year with COVID, and people read a lot of stuff on the internet. And this guy was talking to his neighbor lady, and she said to quit taking your aspirin. She heard that that was bad for the COVID. Same for lisinopril, that ACE inhibitor. Well, guess what? There's been clinical trials to show that you should not stop your ACE inhibitor in light of COVID. That's bad advice. And then she told him to start taking ibuprofen around the clock. It will keep the COVID away. Well, once again, time out. That's not going to work. And in a patient with heart failure, in fact, that's going to make it much worse. So watch out for that. And then there was a blurb about famotidine helping to prevent COVID. And that basically has been debunked. So it's not going to hurt him, but he's kind of wasting his money. And then hydroxychloroquine, which that we were told, last year that this might help. She gave it to him because her grandson bought it online from Mexico or something. I've heard different versions of this with some of my patients. But long story short, we don't want him to take these. So I apologize for the complexity of this. It was going to come in one at a time, but I want you to think about your doctor or your pharmacist or your nurse practitioner or PA. These are the things that we think about every day when we look at a regimen like this, and we try to make your life simpler, but we want to make sure you're on the right pill. So for this case, we wanted him to start taking his aspirin again. We switched that furosemide to torsemide because it's absorbed better. We stopped the lisinopril and we went with the Arni, which is also known as Entresto. We stopped this famotidine because he didn't need it. We tell him to stop that ibuprofen and hydroxychloroquine. We might consider one of the newer drugs. And remember, he's also on Metamucil. So remember my tip of the day there. We have to make sure you don't take that within 1 to 2 hours. And this was my final fanfare, was this was going to blow in. Don't always listen to your neighbors. So hopefully that's good advice. So we're wrapping up here. But what my message to you is, please take charge of your heart failure. Order your medication refills before they run out. Figure out a system. Order them ahead of time. We talked about therapeutic lifestyle choices. The more that you keep removing, watch your diet, listen to, watch the salt, you're going to be so much happier and feel so much better. A lot of you, we need you to weigh yourself daily. And we need you to get on top of it. We can see that early warning sign of a heart failure flare-up, and we can jump on it with some diuretics and cut the salt. And most importantly, I can't prescribe a pill for this, but reduce the stress in your life. Consider whatever might reduce stress for you. I used to think fishing reduced stress for me, but sometimes it makes it more stressful, but I'm having fun, right? But think about mindfulness. Again, the timing on this is bad, but I want you to think about weighing yourself. And I've found that if you hold a bunch of balloons, it doesn't really help, but it might make you feel better. But on a serious note, this is serious. Mindfulness, it's kind of a newer movement, if you will. Maybe you've heard about this, but it's about focusing on the present, being fully awake in your life, focusing on not worrying about what's going to happen tomorrow or dwelling on the past. And if you think about what mindfulness can do for you, it can reduce stress. It can help your productivity. It can do lots of wonderful things for you. And we actually do offer mindfulness services here at Essentia. So this is my prescription for you, laughter. Laughter is the best medicine, except for treating diarrhea, I found. So don't tell jokes to people who have that. But most importantly, I guess one of my take-home messages tonight is be good to yourself. And I'm going to finish with this cartoon that helps me remind that. And I've showed this to many of my patients. To prevent a heart attack, take 1 aspirin every day. Take it out for a run, then take it to the gym, then take it out for a bike ride. In other words, keep her moving. And that's kind of how I look at it. So anyways, I covered a lot. I went kind of quick, but I hope that that was helpful for you to think about how you might look at the way you take your pills, when you take your pills, maybe take them more with food, maybe spread them out a little bit. But more importantly, if you're questioning it, check it out with your pharmacist and see if you can get some advice there. So that concludes the program part. So we're now to the point where we can invite you to ask questions into the chat box, and I'm going to jump to those here. And I'm not sure if the raise the hand button will work with the audio here, but we could try it if we needed to. But let's just start with some questions. And hopefully, respectfully, I'd ask you to please keep your questions focused on heart failure related medications. I can't tell you why your medications cost so much, or here, talk about something that has to do with something that's not related to heart failure. But so let's see if we can answer some of your questions. And I'm guessing that you might actually be able to see these with me here. So well, the first question here is, why does the lung develop fluid? That's a great question. I tried to answer it even though I went quickly. But again, the heart is having a hard time pushing the blood to and from the lungs. It doesn't pump as well as it did. The pressures might be a little bit higher. And there's actually so much pressure that blood, instead of flowing through the heart and going on to do its thing, it pushes back, kind of like that bicycle tire. And that fluid can literally leach out. It's almost like a sponge, and it kind of squeezes that fluid into your lungs, and it can be tough. Again, I'm not a cardiologist, I'm a pharmacist, but that's my version of how that can potentially happen. It's actually a little bit more complicated than that. But that, in simple terms, that's kind of how that works. So I'm going to move on to the second question. And this one says, if you need to take a Tums or Rolaids, do you need to wait for so long after your heart medications? Excellent question. So Tums is calcium carbonate. Rolaids has some magnesium in it. Generally, they're not as bad as like the Melanta or Pepto-Bismol. But yes, if you want to be optimizing these, the optimal way to do this, if you're popping Tums and Rolaids, would be to try to take them an hour apart from your heart medications. The good news is that Tums doesn't interfere as much as some of the others. But if you want to just totally optimize your medications, you would want to think about spacing it out by about an hour or so from your medications. Great question. Thanks for asking that. All right, and the next question I see here is, where do cholesterol medications fit in on the schedule regimen? Excellent question. For a lot of you who have gotten heart failure from either a heart attack or consequences of atherosclerosis, we need to be aggressive. If you have coronary artery disease, if you have plaque in your arteries, or another way we check it sometimes is a coronary artery calcium score, but it shows us that there's plaque there. These cholesterol medications basically are statin drugs. So Lipitor or atorvastatin or Crestor or rosuvastatin. These drugs have been studied extensively, and they've been shown to reduce your risk of having another heart attack or even dying. They reduce mortality, they reduce death. And some of you may think, well, my cholesterol wasn't that high. Well, A, we're redefining what is high cholesterol, but B, even with lower cholesterol, we're starting to learn, there's some research that would suggest, we need to even be thinking lower on that LDL. We used to target, say, an LDL, I call it the loser cholesterol, of say below 70, if possible. But there's even new research in some cases that even if we even get it below that, it might be better. But even regardless of what that level is, we know patients that take their statins live longer. and they have a lot less heart attacks and strokes and other complications. So I'm not sure if that asks you where they fit in the regimen, but I will just throw one little pearl there, is if it is a statin, I usually recommend those in the evening. They work better. Your body makes cholesterol when you're sleeping, and statin drugs don't block cholesterol. You can't just take or you can't just go to the Pizza Hut and load up on eat a whole pizza and then think, well, I'll just take an extra Lipitor or Crestor and I'm good. Well, it doesn't do that. It stops your liver from making too much more, and your liver makes it when you're sleeping. So they say never kick a man when he's down. Well, can you think of a better time? So you want to hit that liver when it's starting to make the cholesterol at night. So if you take the statin after supper or just before bedtime, it's kicking in when the liver is trying to make more cholesterol, and it knocks it down. So maybe that's another way to answer that question. Where does it fit in the schedule? I generally recommend those statin cholesterol drugs be taken at night. Now, can you take your Crestor in the morning? Yeah, you can. But if you want to optimize it, it probably works even just a little bit better if you take it in the evening. All right, let's see. How about an as needed order for Lasix? Do you need to have your potassium checked? Great question. There isn't a single answer to this question, but we do have a lot of patients who have extra Lasix available, or furosemide, should their ankles start to swell or they've gained some weight, and we want to get rid of some of that fluid. But when you take more Lasix, your body also gets rid of more potassium. And so should you get your potassium checked? That's up to your doctor or your provider. If you're doing it just once in a while, probably not, but it also has to do with your history and how well your kidneys are working, where your potassiums have been. So there isn't, I'm being wishy-washy, but there isn't an exact answer here. It depends on the patient. For some of my patients, I would be very worried. I'd say, yeah, oh, you started taking extra Lasix. I do want you to come in and we're going to check that potassium level because we want to make sure. But as a whole, though, occasional use, it shouldn't have a huge impact on the long term there. Okay, so I got more questions here as I scroll. All right. So in a patient with heart failure, what does elevated carbon dioxide levels indicate? Okay. Well, CO2 or carbon dioxide or greenhouse gas, right? It's kind of complicated in a way. I'll try to simplify it. But we don't want our CO2 levels to get up too high. It might mean that our heart, as well as our muscles, aren't using oxygen efficiently. Or we may not be getting delivery of oxygen. And so you get maybe, I don't know, different types of, respiration, anaerobic respiration. I'm going to kind of wimp out here and say, if you personally have higher carbon dioxide levels, there could be more than one reason why that's happening. And I would want you to talk to your doctor about that, or I would have to know more about that case. But it's certainly one of many things that we measure when we do blood tests, and we want to check to make sure that your values are within normal limits. And if things get out of whack, we need to start doing figure out the puzzle to what can help fix that. Again, I didn't completely answer that, but hopefully that helps. And then I'm going to defer you to your doctor to help explain why is your carbon dioxide level elevated. All right, here's a question. You touched on a concern about Metamucil and medications. Is it a problem if I take medications with high fiber breakfast cereal? I have good news for you. The answer is not a problem. There's not enough refined fiber in, say, Raisin Bran or Fiber One. But if you're taking Metamucil, the psyllium powder, the refined powder, or even Citrusol in a way, much more interactions. But if you want to take your morning pills with a little bit of high fiber cereal, great. If you're eating 2 boxes of cereal, well, then we'll have to have another conversation, but I think you'll be okay there. Okay, so now I'm going to jump into the chat here, and I have a question here. How does a doctor decide which category of blood pressure med you need? Great question. Well, the categories have to do with your clinical condition. And if you have heart failure, there's more than one kind of heart failure, but one way to simplify it is we have kind of two groups here. We have those that have the preserved ejection fraction, generally about 40%, and then we have reduced ejection fraction. And they actually have different rules. So based on research, we decide, well, okay, this patient now has reduced ejection fraction. So now I'm going to be more aggressive with adding, that ACE inhibitor, the ARB, or that ARNI, that Entresto type drug. Also, the dosages, not only which category, but what dose to target for like a beta blocker from metoprolol. That page I showed you with all the medications on it, it's a little bit complicated, but that's the research that shows that, if they have this situation, these are the drugs that we need to have them on, as well as target that dose. Again, may have not completely answered your question, but we have to know what's going on with you clinically, as well as, or do you have super high blood pressure as a rule, and we need to be more aggressive with that, or do you have other issues going on? So there's other factors that would impact that decision. All right, another question here. When is the best time to take warfarin? So warfarin is a blood thinner, and we generally recommend we take that just before supper time. There's nothing magic about that as far as how it will do it for you clinically, but we need to monitor warfarin a lot of times in the clinic. And generally, when is that? It's usually say between 10 a.m. and 3 p.m. in the afternoon. And so if you take it the night before, it's been in the body for about an 18-hour soak or so, and then we can get an accurate INR, and it helps us to judge whether or not we need to adjust your dose. If you're doing your own finger sticks at home, then maybe you can take your warfarin in the morning, but then you would want to check your INR, probably at, just before you go to bed. So there isn't a perfect time, but in general, we generally recommend warfarin at night. I've only got a couple minutes left. I'll see if I can answer a couple more here. I thought that drinking 6 to 8 glasses of water was recommended if I am not on a diuretic. Is it okay? Now that I can't tell you that. You need to talk to your doctor, because when we decide fluid restrictions or fluid recommendations, it's sort of on a case-by-case basis. They need to know what's going on with you. And yes, when you take a diuretic, it can impact that, but it's about balance. And I can't really answer that directly because it's case by case. And I think you need to talk to your daughter, talk to your daughter too, talk to your doctor. But in general, we try to restrict fluids in heart failure, because if you get too much fluid, it makes it so hard for the heart. I might have time for, oh, that's not a question. Okay. So I believe this is going to be recorded. So for those of you that wanted to see this again, or for a friend that would want to see it, I believe our friends here at Essentia, April, might be able to help with that. And so with that, I am out of time. I'm going to ask my friends here, is there anything else that I need to do?
That's it. Thank you everyone for coming.
Okay, fantastic. I apologize if I didn't get to every question. My name again is Richard Mulvane. If you have a personal question, you're welcome to reach out. You could literally call the Heart and Vascular Center here in Duluth, and they could get a message to me, and I'll try and call you back. Other than that, thank you so much to the folks that helped set this up. Thank you to Dr. Carl Heltney and the Heltney Endowment, and Denise Buxbaum for helping set this up. And I'm just going to close with what I had said already earlier. Be good to yourself and keep her moving.